Welcome to the second part of this presentation regarding focused ultrasound, where we will look at the results of the procedure. And firstly, it goes without saying that bilateral DBS will reduce bilateral tremor more than unilateral DBS or FUS. Therefore, let us focus on comparing unilateral DBS with unilateral FUS, especially since bilateral FUS is not commonly performed. And if we look at the marketing information, then we'll find unilateral thalamotomy to be very effective with an average tremor reduction of 73% even after 5 years follow-up. According to this review of Giordano, unilateral FUS is as effective as unilateral DBS regarding tremor reduction, but with a better quality of life. And this has now often been repeated in various papers and presentations and seems to have turned into a meme. But some caution is necessary when interpreting the results. There are no randomized studies comparing FUS and DBS, so I will take this review as my starting point. This review of 441 FUS thalamotomies versus 1158 VIM DBS concluded that the methods were equally effective but with better quality of life for FUS, 62 versus 53% improvement respectively. However, already when we notice that there is almost no difference in tremor reduction between bilateral and unilateral DBS, it seems clear that something is not right, and this is probably a reflection of the heterogeneity of the included material, which is not providing a comparison of equal entities, not even of apples and pears, but rather a fruit salad, perhaps even with a tendency to some cherry picking. If we look at the included studies, then all of the FUS studies were recent and done over 7 years' time, while the data for DBS stretches over 24 years, and it is a very heterogeneous material. The major problem is that the reported tremor reduction is for some studies total CRST score, for others it is tremor reduction in the treated hand, and yet for others only axial tremor or other variations. And as you understand, there will be a great difference between the total score and the hand tremor score of the treated side in a unilaterally treated patient. Secondly, many of these studies are reporting the same patients and the same data again and again. And thirdly, and most importantly, the selection of which items and numbers to report have resulted in a biased outcome favoring FUS. Of the DBS studies in this review, no less than 9 are mine, and I will use the last one of these as an example to demonstrate the problems. But let me first point out that I'm not criticizing the studies mentioned here, but how they have been read and recounted. And this is also true regarding the first paper by Jeff Elias, a colleague for whom I have the utmost trust and whose advice I have often sought. In this paper with 15 patients, the review is here using the total CRST score, which was 56% for FUS, compared to 60% for my DBS study. And these same patients are then reported again in this paper. And then we have the well-known randomized study by Jeff Elias et al., where the improvement of the total score was 35%, and I can also mention that the hand tremor score improvement here was 40%. But in the 2-year follow-up of the previous study with a few added patients, the results at 12 months have improved dramatically from 35 to 56%. But this is just an illusion. The review has here switched from the total CRST score for the whole body to the hand tremor score for just the treated arm. But the improvement here of 56% for the hand tremor score is still being compared with my total score for the whole body, even though the improvement on my hand tremor score was reported and was 86%. It is also interesting to note that the improvement in hand tremor score had now increased from 40% in the last publication to 53% by merely adding 14 patients to the initial 56. This improvement is actually too large to be explained only by these 14 patients, but must include also other factors, and I have been told that this is probably due to a switch from the blinded to the unblinded scores. This problem is then repeated in the 12-month data as reported in the 3-year follow-up, where the hand tremor score at 12 months has improved further to 61%, probably due to 31% of the patients having dropped out. And also in the next paper, where a further 114 patients were added, is the hand tremor score used and compared with my total score. And this is also the case regarding the 12 months data in the 4-year outcome of a part of the patients from the randomized study. In the next paper by Sinai et al. Of 44 patients, the median is provided instead of the mean, why it is difficult to compare with the other studies. Thus, in the review, many of the FUS studies were presented as much better than DBS in my hands, while in reality we have presented a considerably better tremor reduction. And this is due to the fact that very different scores from the CRST are being compared, mostly either the total tremor score for the whole body or just the tremor score for the treated arm. And it goes without saying that the effect is much better in the treated arm than in the untreated arm or the rest of the body. Had this been done completely randomly, it might not have been this disturbing. But it seems as if the more favorable hand tremor scores have been mostly used for the FUS patients and the more unfavorable total score for the DBS patients, even if this is not consistent. Let us now try to look closer at the numbers, and let us remove the multiple inclusions and keep only unilateral procedures which are reported with mean values and items that can be compared with the CRST items reported in the FUS studies. Then we can keep 5 DBS studies, of which I have changed Sidov et al. To the earlier publication from Limousin of the same patients, since it has more details. Of the FUS studies, most are removed since they are just reporting on the same patients, and we keep the original study by Elias with 15 patients and the later study by Krishna on 189 patients. Krishna's paper included the patient from the randomized study of Elias. However, as I mentioned, there was a major and unexplained improvement in the 12 months outcome from the randomized study to the 12 months outcome in the subsequent papers, mostly on the same patients. Thus, I assume that we might get a more accurate representation if we include also the outcome from the randomized study. This can be questioned, and if you disagree with this, then you can simply recalculate the numbers seen here. In this manner, we end up with about 200 unilateral patients in each group. We then see that the hand tremor score was improved with 74% after DBS and with 58% after FUS. Considering the heterogeneity of the material, one needs to be careful with the interpretation, and I will leave it to you to decide if this difference is trustworthy and/or relevant. Interestingly, ADL, which in the review was largely used to calculate quality of life, was actually better with DBS, where it was improved with 70%, compared with FUS, where the improvement was 65%. How is it then possible that the quality of life was claimed to be considerably better after FUS, 62 versus 53%? Well, quality of life was mainly reported by using Part C of the tremor scale, activities of daily living for the FUS studies. But regarding DBS, even if ADL is reported in the original studies, scales where DBS always have a more modest percentual effect have instead been frequently used. If we look at the 4 DBS papers with the lowest quality of life according to the review, 35, 40, 37 and 36% respectively, then we find that this was with Quest, PDQ 39 and other scales. But all these studies reported also the ADL, and had that been used, the corresponding numbers would instead have been 73, 71, 69 and 68% improvement. the mean improvement of the worst DBS studies were still higher than the mean improvement for the FUS studies. Thus, if they instead had reported the ADL in the same proportion as for FUS, the quality of life would have been much higher for DBS. So, there is nothing in the literature suggesting unilateral FUS to have a better effect than unilateral DBS on tremor reduction or ADL and quality of life. If we look specifically at axial tremor, then the effect of FUS on head and voice tremor is most often not presented, but seems to be limited. This is in contrast to unilateral DBS, where the effect is often pronounced. Thus, in patients where axial tremor is a major concern, DBS might be preferable. Let us now continue and look at the long-term outcome. In the randomized study, the focus was on total CRST, which improved with 35%. In the following yearly evaluations, the focus was switched to the hand tremor score of the treated hand, which increased from 40% at 12 months in the first paper to 53% in the following papers, but which after 5 years had decreased again back to 40% after 5 years follow-up in the remaining 40 patients. And in that publication, the focus was changed to postural tremor in the treated hand, which was improved with 73%. From a clinical perspective and from the patient's point of view, this item is of rather limited importance if you are not an ancient Roman or an adherent of some more modern dark ideology, at least compared to total CRST, hand tremor score including hand function, or even compared with action tremor of the treated hand. Anyhow, the hand tremor score was, as I mentioned, also provided in this study, as well as the ADL score. Unfortunately, there is not much to compare with regarding the long-term effects of DBS, especially if you want to have the same scale and the same reported items and unilaterally stimulated patients. In the European multicenter study, CEDOV reported an improvement of postural tremor with 70% after up to 7.7 years follow-up. I published an improvement of postural tremor with 80% and the hand tremor score with 44%, where we had excluded item 10, and no significant improvement of ADL after up to 9 years for VIM DBS. However, all these patients were operated more than 25 years ago, and we have since improved the procedure much. And recently we published our 10-year data, where the hand tremor score was improved with 76%, and item 5.6 contralateral tremor at rest, postural and action was reduced with 91%, and virtually no patient had any residual postural tremor on stimulation, and ADL was improved with about 49%. Some say that thalamotomies in general are preferable to DBS in essential tremor due to a supposed better long-term outcome. Based on my own experience, I would say that the long-term outcome with modern DBS is quite good, even if there are individual exceptions. However, that is just a personal opinion. Further, we know very little about the long-term outcome of radiofrequency thalamotomies. We did a study on 9 essential tremor patients 20 years after thalamotomy, and none of them considered themselves to have any effect left, and all of them had severe tremor and would have been candidates for surgery based on this. There are also some other studies, but it is difficult to form an opinion from these studies from the old lesional era due to the heterogeneity of the material and lack of adequate scales. Sometimes the survey by letter performed by Mohajer in 1990 on Mundinger's patients is mentioned to support a good outcome, and 69% of the patients had at least a substantial tremor reduction. However, it is important to notice that these patients were mainly lesioned in the posterior subthalamic area and often in combination with other targets, as was Mundinger's practice, while FUS thalamotomies are mainly performed in the VIM itself. Thus, it is very difficult to say anything with certainty about the long-term effect of radiofrequency thalamotomies for essential tremor, especially anything with bearing on FUS thalamotomies. If I may venture to give a non-expert opinion, then I would guess that unilateral FUS is probably providing a good level of tremor reduction, and for many patients this is probably good enough, even if I believe that it will not be as good as DBS. FUS is probably good when it is working well, but my guess is that it will be working well in somewhat fewer patients than DBS. Remember also that radiofrequency thalamotomies were about as effective as DBS, and the reason why we abandoned them was not because they were not effective, but because we got fewer severe complications with DBS, and this made bilateral surgery possible. Regarding FUS, there is little doubt that complications and side effects are common. They are very common immediately after the procedure, mainly due to the postoperative edema. And let us, as an example, look at this report by a very experienced and honest group, who reported their experience of 160 patients. As we see, about 55% of the patients had gait imbalance, 25% sensory deficits, 20% dysarthria, and 10% motor weakness. Short-lasting side effects might be easily accepted by the patients if they are well aware of these and see them as a part of the package. However, if we look at the persistent side effects, then also these are rather common. After 2 years, 20% of the patients had still affection of gait and balance, and 10% had sensory deficits. I believe that this group is somewhat more aggressive in their treatment, and other groups have reported fewer side effects. An interesting question is if we have more or worse complications with FUS or DBS. What is clear from the literature is, of course, that the complication profile differs a lot between the two techniques, not least regarding the temporal distribution. At first glance, I would, at least in my own hands, deem DBS as a safer option. We avoid some complications on the route to the target area with FUS, and all hardware-related complications, but on the other hand, we have a high percentage of permanent side effects. However, I can understand that others might have a direct opposite opinion, and I find it exceedingly difficult to make an objective evaluation based on the published literature, and I will have to ask to get back to this question after I have performed a randomized study and made a direct comparison. So, to conclude, regarding unilateral procedures. Unilateral thalamotomy is probably a good alternative to unilateral DBS in the older population, and especially in patients deemed too old or too frail for DBS. In young patients, DBS might be preferred, especially considering the uncertainties regarding the long-term effect and the not insignificant risk for permanent complications. Bilateral thalamotomy has been FDA approved based on a few patients. We know that when making bilateral lesions, we are not simply doubling the risk for side effects, but the brain is more sensitive to bilateral interventions, and for that reason these are done as a staged procedure in order to let the brain recuperate. Further, it is also common to make the second lesion in a slightly different place and to make it smaller. However, presumably, one has chosen the optimal size and location when performing the first lesion, and it is common that the effect of the second lesion is not as good as for the first one, or at least this was common for the radiofrequency lesions. But it is mostly the side effects that are of interest here. If we look at this study of Lozano of 10 patients, then 3 months after the last lesion, 6 patients had persisting side effects. In the second study here of 11 bilateral thalamotomies, complications from the first lesion seem not to be reported, but after the second lesion, 3 patients had persistent affection of the taste, interfering with oral intake. In the third, 1 of 5 patients had permanent dysarthria and discomfort in the tongue. In the last study of 9 patients, no permanent adverse events were registered, and these were mainly transient. More studies are needed, but I think that we need to have respect for bilateral thalamotomies. My non-expert opinion on bilateral thalamotomies would be that bilateral radiofrequency thalamotomies were seldom done due to the high risk of side effects. With better MRI-guided FUS, the risk can probably be reduced. However, it is likely that bilateral lesions will, in expert hands and in well-selected patients, still come with a significant level of permanent side effects. More studies are needed, but I would guess that unilateral lesions will be the standard and bilateral the exception, and DBS is probably a safer alternative than FUS in bilateral procedures. Thus, patients in need of bilateral surgery should preferably be treated with DBS, considering the very limited experience of bilateral thalamotomies and our limited knowledge regarding effects and side effects, especially over time. Even if the choice stands between unilateral DBS and unilateral FUS, patients with voice and head tremor should probably preferably be treated with DBS. Younger patients should preferably be treated with DBS, considering the uncertainties regarding the long-term effect and a not insignificant risk for permanent complications, while FUS might be more appealing in the older population. Patients not suitable for DBS due to age or other circumstances, including strong personal preferences, should be considered for FUS. Regarding thalamotomy for Parkinsonian tremor, there are a few studies, but not as much as for essential tremor, and the results does not seem as good. And there is a lot of complications as seen in this study of Bilateral, which was the basis for the FDA approval of this indication. In 20 patients, they achieved a tremor reduction of 62% in the treated arm, but at the cost of many complications, including 2 permanent hemiparesis. And the long-term effect in Parkinson's disease is also more uncertain. Some studies have demonstrated a more or less sustained effect over time, but others have noticed a clear deterioration, like in this study by Steve Tisch, where no remaining improvement was seen after 2 years. Based on personal communications, it seems as if it is a commonly shared experience that it is more difficult to get a good effect on Parkinsonian tremor. I find it surprising that the effects on PD tremor are so modest, since with radiofrequency thalamotomies as well as with DBS, it is usually easier to get a good effect on Parkinsonian tremor than on essential tremor, and I don't know why this should be the case, or if it will be possible to improve the results. For FUS Pallidotomy, the effect is advertised as 69% efficacy response based on the randomized study. In this trial, 31% of those with unilateral pallidotomy were not responders, and 32% of those with a sham procedure were responders, and the response was defined very low at a mere 3 points improvement. The mean total UPDRS free score at baseline was 29, which was reduced with 6 points or 21%. The improvement after radiofrequency pallidotomies was typically around 25%, but often after a much longer follow-up in patients with an UPDRS that was very much higher. And it would be interesting to know the effects of FUS after 1 or even 2 years, rather than only after 3 months. Further, it seems to be a common opinion that the GPI is probably too lateral to be a good target for FUS, and that it is difficult to shape and center the lesion in a desirable manner, why it seems unlikely that FUS pallidotomies will become common. Regarding investigational procedures, unilateral ST and DBS has been researched mainly by the group of Obeso, who has performed radiofrequency lesions in the STN for many years. The effect seems to be good, but the published side effects are considerable. Considering the sensitivity of this area, it seems unlikely that bilateral procedures will be frequently performed. Likewise, rather few patients should be candidates for a unilateral procedure. With that said, I think that this is an exciting indication and that it has a lot of potential. There are also some small studies on other parts of the thalamus for Parkinson's disease, dystonia, pain and epilepsy, but these are of more peripheral interest. So, to conclude, FUS is an exciting and often effective tool, and some good studies have been made documenting the effect. However, sometimes these studies have not been read in a careful manner. Further, there are no studies directly comparing FUS with DBS, and when discussing these two techniques, it is on the one hand important to remember that FUS is a new technique that is developing and that we are likely to see improved results in the future. But on the other hand, it is likewise important to realize that DBS is also becoming better and better, and we should not compare FUS with DBS performed a quarter of a century ago, but with modern DBS. Anyhow, as I said, FUS is an exciting tool, but when I bought one I did not only have to ask questions about the efficacy, but also on the potential number of patients, the market, costs and such. So please have a look also at the next part, where you might find some interesting thoughts and decide if this is something for you. Thank you for your attention.